welcome today to our ATI seminar series. My name is Mariko Boulay. My connection to the ATI is that I'm a part of an angel donor family. My brother, Logan Boulay, was on the Humboldt Broncos team and tragically lost his life in the crash. We were very fortunate to be able to donate his organs, and it welcomed us into this world and this family of organ donation, transplant awareness. And we're coming up to the 6-year anniversary, which is crazy, April 6th and 7th. But I feel like now that we've come farther along, I'm able to be more open and welcoming into this, again, this organ donation, transplant awareness world, and then also honoring and loving and caring for my brother, Logan. So before we begin, I just would like to, one more thing too. Sean did share in the chat about Green Shirt Day, which is the day where we honor and continue to support organ donation awareness and honor my brother Logan, as that is the anniversary of his passing. That is April 7th. Please wear your green, as you see that some of us are wearing ours today, and just continue to have that talk with your family, your loved ones about your wishes with organ donation. So before we begin, I'd just like to give a land acknowledgement. We acknowledge that the University of Alberta is located on Treaty 6 territory and respects the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. Also, thank you to Paladin, Astellas, and AstraZeneca for their support of the ATI seminar series. So our speaker today is Dr. Samara Zavalkoff. She is an attending physician at the Pediatric Intensive Care Unit, the PICU, of Montreal Children's Hospital and Associate Professor of Pediatrics at McGill University. She is the Medical Officer of Patient Safety and Quality Improvement for the PICU since 2010, is a certified Canadian Patient Safety Officer since 2013, and has completed the Excellence in Quality Improvement Certificate Program at the University of Toronto in 2018. Since 2021, she is an inaugural Medical Director of Safety for the Montreal Children's Hospital. Her academic work focuses on improving care processes in the ICU, including team communication, infection prevention, and optimizing potential organ donor identification and referral, as well as gender equity in medicine and critical care.
Thank you so much, Mariko, for that introduction, and to ATI for having me. It's really, I just said to Mariko, an honor. We're all striving towards the same goal of increasing organ donation in Canada, and the circumstances, obviously, that her brother had, his impact, are very tragic, but it's very, very empowering to see the impact that he has had across Canada, and glad to be here with you, Mariko, today. So we're going to spend the next little bit together. Sorry, give me one sec to get this up for you, and we'll leave lots of time at the end for hopefully discussion and questions. And I hope today what I'm going to do is give you a little bit of a different way of thinking about organ donation than maybe some of the other presentations you've heard or other discussions you've had in the past. So what we're going to talk about today is preventable harm and patient safety as it relates to deceased organ donation. So in terms of disclosures, I have received funding both from Canadian Blood Services and Canada's Organ Donation and Transplant Collaborative to do quality improvement work and donation research on this topic that I'm going to speak to you about today. And our 3 objectives for today are to understand how important it is that we make referrals and identify donors in a timely way, that we start to think about those missed or delayed referrals as a form of preventable harm and patient safety events. And then to sensitize you to some of the donation work, the work that we're doing in the national scene in terms of deceased donation data. So my other disclosure is that many years ago, and you heard Mariko go through, the different things that I've done in terms of training and such, is that I didn't begin my career in the donation world. And I still consider myself more of someone who's an expert in patient safety as much as somebody who's an expert in donation. But what I've learned being involved in this work for the last 8 or so years is that there is a lot of connection between the two. And so what you see here is our Montreal Children's Hospital logo, our program that's called Mission Safety. And I do feel there's a lot of safety work that lends itself to the donation world. So I'm going to start with a non-donation story. And this is a patient who I might see while I'm on call, as I was last night in the ICU. So this theoretical baby is 6-month-old. She came in with some fever, difficulty breathing. Looks like it's probably a virus. It's that time of year. The medical ward admits her for oxygen and observation. Over the night, the child becomes more irritable. It's hard for the nurses to get vital signs. They get a really high heart rate, but the baby's really irritable. She's crying. Maybe she's hungry. They're not sure if that heart rate is really accurate. They try to measure some blood pressures, but she's moving a lot and she's quite small and the cuff is maybe too big. And over the next night and into the next day, the baby's breathing more quickly, needs more oxygen. And the trend in these deteriorating vital signs is not really recognized because of all these confounding factors until the next night when the baby loses consciousness, the blood pressure cannot be measured, pulses cannot be felt, a code is called. The code team is able, thankfully, to resuscitate the baby, and the blood cultures quickly that are drawn grow strep pneumonia. So an event like this would be brought to me as the safety director of the hospital. And we now have a very clear process that we undertake for a big safety event like this. The first thing is we huddle with our executive team, both our executive hospital team and the safety executive team. And what we talk about in that meeting are the immediate steps that need to be put in place to protect the next patient. We will categorize the event. Is it what we call a serious safety event, which means that it fulfills 3 criteria. One is that there was a deviation in standard practice. The second is that deviation reached the patient. And the third criteria is that by reaching the patient, it caused a harm and that harm was severe. So if it fulfills those 3 criteria, we would call it an SSE or a serious safety event, and that would trigger a whole formal process. We'd also talk about how we need to immediately support the team that was involved in taking care of this child, who most likely all showed up at work that day to do their best and provide excellent care, and this difficult situation unraveled in their care, as well as, of course, the child and his or her family, who are all going to be affected. We would then undertake this more in-depth review and analysis. What were the root causes? What were the system issues? What can we do next time to prevent it? Were there any, what I call people issues, people who might need more training or guidance? And then we would identify interventions that match the root causes and ensure that they're implemented effectively so that this doesn't happen again. And of course, we would make a disclosure to the family, where did we go wrong? Where was the system not set up properly? How are we going to change the system? So that's kind of our model of when we have one of these serious safety events. And you'll see how I'm going to tie it back in a moment to organ donation. So we're going to switch gears and I'm going to tell you a different story that's an organ donation story. And this is a young boy who's 7 years old, who had been healthy up until the age of 7, and then presented with end-stage dilated cardiomyopathy. And you can see here in the picture on the left and the right that he required a ventricular assist device and remained in hospital for 14 months because this large device, that is the only device that's approved for children, called the Berlin heart, cannot be provided as an outpatient. So you can even see here in the middle, for those of you who are hockey fans, so ties nicely with Mariko being here, is a very famous hockey player. You can probably most of you recognize PK Subban. So when we look at this child, we have to remember that there is a cost in various definitions of the word cost to this therapy. So in my world in the pediatric ICU, when we take care of one patient on a VAD like this, that is similar in cost to taking care of 30 other children with a variety of diseases. And in Canada, that's amounting to about $1.6 million, and that is not including the physician costs. And then there's a cost psychosocially in terms of keeping a child in the hospital for months on end, not going to school, social life completely derailed, families, work life completely derailed. And then finally, there's the good and the bad of the story where, there is a survival that's quite significant when you go on such a device at 60 to 70%, but it's not 100%. And we know this from the Canadian heart wait list data from Canada, that up to 30 to 50% of children and 20 to 25% of adults will withdraw from the wait list because they've now become too unwell to continue to be listed, or will die on the wait list. And so this is it's not a benign treatment. The good news is that for this young boy, he was fortunate enough to receive his heart transplant and go home very quickly after that successful transplantation. So let's back up. Why am I telling you this successful story at the same time that I'm telling you about safety events? So 2 days before, somewhere else, there is another 10-year-old child who presents to an ICU with refractory intracranial pressure related to a severe brain infection and an underlying neurologic condition. He's comatose, and after a few days in the ICU, it's clear that his prognosis is quite dismal, but he has not fulfilled criteria for death by neurologic criteria. The family is met, the prognosis is explained, and the parents decide that the best course of action for their family and their child is to withdraw life-sustaining measures, draw the ventilator the next day. And for an unusual reason, the doctor on that night was not going to be the same. The doctor on that day was not going to be the same doctor the following day. And with the shift change, there is suddenly this recognition that perhaps this is a patient who might be eligible for donation. And this is explored with the organ donation organization. And then the family is approached, and the family is extremely motivated and agrees to offer their child's organs in donation. And in the time that it takes, as we know, it's a lengthy process to proceed to the donation. The child evolves into neurologic determination of death, and thus is able to be the donor for the first patient that I showed you. So, in organ donation, I think many of us would look at this story and say, what do we call this? We call this a successful transplant. But when I look at this as a patient safety expert, what I see is a near miss, because I say, what if that shift change hadn't happened? What if the new doctor or the new team member hadn't asked the question, hadn't identified the patient? We could have missed this whole opportunity. So let's imagine that it hadn't gone through, the shift change hadn't happened, and the donation never occurred, and the transplantation had never occurred. In patient safety, I would argue that we call that a serious safety event. And in donation, in the current system we have, we might call that a missed donation opportunity, and that's a term that we're trying to really advance. But in many areas and jurisdictions, we might not call that anything at all, because it may not even show up on the radar that missed identification and referral happened. So I'm just going to break it down for you now as to why I consider this a serious safety event, because I'm hoping by the end of this time that we're together, that your mindset is going to change, and that you're going to start to see these missed opportunities for donation, these missed identification and referrals as potential serious safety events. So back to the criteria. The first is, was there a deviation from standard practice? So there is what we call mandatory referral legislation, and the goal of obligating us as the healthcare team to, in a mandatory way, refer to the ODO is so that the ODO can check the registry and see if this patient had the intent to donate, and to start making some early evaluations of eligibility. So many provinces and countries do have mandatory referral legislation that tells us this is what we have to do near end of life. In Canada right now, we have 5 provinces with this. But even if it's not law, I would argue that it's become the standard practice that we owe all Canadians the opportunity and the choice to become organ donors. And so by not even making the identification and not making the referral as appropriate, that we are deviating from standard practice. The second question is, did it reach the patient? And you can see I've kind of changed the language to, did it reach a patient? Because in my scenario of the young baby who has septic shock, we have that particular patient who we didn't maybe identify, do blood culture, start antibiotics. Whereas here, the harm that we do by not identifying and referring the patient in front of us who's at end of life, the harm is somewhat to that patient because it does deny them and their family the opportunity to organ donation and the positives that might come of that if they so choose. But it also does a harm that's unmeasurable to a nameless, faceless patient somewhere else in another province, in another part of Canada, or even in another country, if there's organ sharing across the border, who might not be able to wait any longer, or who might be suffering additional morbidity by waiting for transplantation. And this is a bit of a frame shift because when those of us who work at the bedside, our duty of care is always to that patient who's in front of us. We don't often train or think as much about the patients who are outside the circle of care that we're providing. I think in COVID, we started to have a little bit of an exposure to this where we had to think about surge planning, prioritization of beds. But I think it's time for us to start to think about the others that are not immediately in front of us. And so that last criteria of a serious safety event is, did it cause serious harm? And again, I would argue it did, because depriving 2 or 3 people, because that's the average what one organ donor will provide in terms of donations, organs donated. If it deprives 2 to 3 people of a life-saving or life-enhancing treatment, that sounds like a lot of harm. And if it denies patients and it denies their families that opportunity to donate and takes that choice away from them, again, I would argue that that is a form of harm. So there's 2 other little quick checks that we do in patient safety before we conclude that it's a serious safety event. And the first one is preventability. Some things are a part of what we do. They're complications. We do a surgery. We know that pneumothorax is a complication. We consent the family. We tell them that. I don't think that this is something that's non-preventable. And we've just spent a lot the last 3 to 4 years working on ways to make sure that it's something we can prevent. And then the other question is it a system problem or a person problem? So we do these evaluations. So the first question is to judge if this was a deliberate harm. This is very, very exceptionally rare. You hear about these cases in the media where, a member of the healthcare team is injecting patients with insulin to give them hypoglycemia. I don't think that the ICU physician who wasn't identifying the patient was doing so to cause harm. Incapacity, if one of us is intoxicated or has a mental health problem and doesn't fulfill our duties because of that. The foresight test, which tells us, okay, let's look, were we able to avoid this? Did we do this because we knew there was a standard operating procedure and we just violated? And then the substitute test where we say, would other people have done this? If yes, if we've done other unsafe things, then okay, we're making errors and we need more training. But if we didn't make unsafe acts prior, then it's what we sort of call a blameless error, which really means that it's a system failure. And the simple way for me to distill all of those tests down is, could someone else in my position or the position of the person who, in this case, failed to identify and refer, could someone else have done that? Could I have done that if I had been on call? Could the nursing colleague I worked with have also forgotten or not known how? And I think the answer is yes. And it's that makes this a system problem, and thus the solutions have to be system-based. So what I'd like to see in this theoretical, world where we would identify we would label a failed identification and a referral as a safety event would be something very similar to what I described of what we did for the patient who had a cardiac arrest from septic shock, where we would, in the same way, huddle together with our leadership, determine if it's a serious safety event, immediately support the team that was involved in the safety event, the family and the patient. We would sit down after each of these events and analyze them and figure out what the root causes were in this particular instance. And then we would take action to intervene to prevent recurrence. And this one is a bit tricky, the disclosure. You know, it's hard to imagine, and this, when I gave this talk at the International Transplant Meeting in the fall, it's hard to imagine, calling someone on the transplant list and saying, we're really sorry, we almost had a donor, but we kind of forgot to call, and, it could have been an opportunity. I don't think that's, productive. But in a similar vein, there are ODOs that do publish very completely publicly, you can Google it, their identification and referral rates. And so patients who are waiting on those transplant wait lists can see that in one province, this is their rate, in another province, it's, another rate. And maybe that should be broken down really granular, and we can have some discussion about that at the end. But the way I perceive it is that the patients that are on the transplant wait list are a very vulnerable population. They're quite sick, they're small in number, and they are completely dependent on the rest of us in the healthcare and donation system to be doing everything we can to shorten their time on the wait list and get them successfully to transplant. And so if everything about their care should be about them, then perhaps they do deserve to have as much disclosure about missed opportunities as possible, and even perhaps engage in the process of improving the system. So taking a step back, why is this important? Probably many of you have seen this data, which shows our patients on the wait list for transplantation in Canada up until 2022, most recently in 2022, 3,777. And the good news of this slide is the blue graph showing the organ transplants that, yes, are gradually improving. And that has been amazing success with significant work from all of the partners in the donation world. But what we still see is that there are 3,777 Canadians who remain on the transplant wait list, and then an additional 270 patients who have died on the wait list. And then a whole number of patients who we don't have a number for, who are withdrawn when they become too ill. So this still remains a very significant problem for us to solve. So colleagues at Canadian Blood Services, and Sean was just telling me before I started that he was part of the team that built this really visually, this visual that tells a really nice story. So, of course, there is a large number of deaths in Canada and represented by all these little green people. But what is often not appreciated is that it's not all of these people who can be in a position to donate, right? They have to have died in a hospital, so that's a smaller number. And then they have to be eligible as potential donors. So now we're down to this much smaller group. And then we're down to a smaller group of those who are utilized, which is, in this particular year in 2022, 823, and then you can see the breakdown of the organs and how many transplants, because on average it's 3 per donor. And so in a way, finding the world of donation is like the world of needles in a haystack. And so here you're just seeing transpose the wait list and the withdrawals and the deaths on the wait list. So essentially the message that I want you to take away from this is, we can't afford to miss one donation opportunity, because the cost of that, when you break down the numbers, becomes too grave. So in 2019, we published this series of recommendations, guidelines, expert guidance from a Canadian consensus conference that had amazing involvement from the donation world, but also those who are involved in donation in various peripheral ways, like quality organizations. We brought families, we brought patients to really look at this issue of donor identification and the accountability that should exist around it. And the reference is here on the bottom, but I just wanted to highlight 3 of the expert guidances that we provided. The first is that are relevant for the discussion we're having today. So the first was the deceased organ donation system has to be resourced and organized appropriately to ensure that all possible donation opportunities are recognized and maximized. So this isn't just about us trying harder. This is about having a system that is resourced and organized to get us there. The second is to really have a formal accountability framework. And I described an accountability framework that might exist at the micro level at a hospital or at an ICU-based level. But this needs to be even at a broader level where missed donation opportunities get reported. We do incident reports when we make a mistake with a medication dose. So we should have reporting of missed donation opportunities, and they should result in an investigation. And then the third was that if a missed donation donor can result in harm or death, as we were just reviewing, then, and it's preventable, it's not that we did our very best and all the processes were followed, and nonetheless, the donation didn't transpire, but that it was preventable, that's something that we should consider a patient safety issue. So I think this is very, very important. We're driven by accountability in two aspects. The one is to the grieving families and the respect to their family members so that they have the choice. And whenever my trainees, I work in an academic hospital, and our fellows will say, it's so uncomfortable, I don't want to put this on the family, look how stressed they are, look how overwhelmed they are. I just say, it's not our right to take that choice away from them. And then, of course, the accountability we have to that vulnerable population of Canadians. So in summary, when we put this all together, if we have a missed donor being a harm, and knowing that this happens and it's recurrent in our system, and we even have places where it's the law and at least it's standard practice everywhere, and we know that transplanting saves lives, improves quality of care, and it can even save money in the case of renal transplants, then I think for me, I'm putting together for you this compelling argument that missed donation opportunities are serious safety events that cause preventable harm. So this was the data just to make the point that kidney transplants after the first year save lives and save money. And this has always been data that has surprised me when I learned it. Many people have the impression you go on dialysis and it's an unlimited resource until you get your transplant, but in fact the survival 5 years dialysis is less than 50%, and it's so significantly improved, more than double after transplant. And this data about cost analysis, so after the first year, because of the savings in dialysis, we're saving the system a lot of money. So we spent a lot of time talking about a missed identification and referral, but I do want to make the point that there are many ways to miss a donor. So we may not identify them, we may not refer them, but then there's other ways. Maybe we don't undertake the neurologic determination of death or death by neurologic criteria exam in the proper way. We don't approach the family in the proper way. Our consent processes aren't optimized, or we lose the donors because the donor management is not optimized. So just to say that we need to look across the entire pathway of donation, but for me, the focus was identification and referral because it's the first step. And if we don't first fix the first step in a process, it becomes less relevant what's happening downstream. So a little bit of data to just show you that this is really a problem. So this is data from Trillium about delayed referrals causing missed donation opportunities. And you can see we start with ventilated patients that are planned for withdrawal. And there's a certain percentage that, of course, are medically unsuitable. But then in the group that are medically suitable, there's 36% who get referred to TGLN before any steps are taken towards withdrawal. But then we have two other groups. This one who get referred at the time of withdrawal, or as it's being initiated, so it becomes too late to get someone on the ground, to meet the family, to make the assessments. And then this small percentage, but every single number counts, of patients who were not referred at all. And so if you account for these two groups together, 251 missed referrals, and you apply the consent rate of Ontario, that gives us about 150 consented patients, and multiplying that by 3 for the average number of organs is just from this one study, 450 potential missed transplants. As well, I'm not sure how many of you work or liaise with colleagues in the emergency department, but we know that there is work to be done there. Some of this data is from the UK, some is from Canada. There are occasions of missed brain death that are not identified, cases of both neurologic and circulatory death that are not identified in time. Particularly concerning in this study, the third picture here of the little phone, is that 16% of the misses were actually patients registered. I mean, I think when we all say sign your card, we're trusting that someone's going to check that I've signed my card and someone's going to call the ODO and confirm that that was my intent. But there was a percentage of times in the UK where that didn't happen. So just to make the point that it's an ongoing need to educate and implement systems in the emerge. And part of it is, is just knowledge gaps and comfort. And this work from Jennifer Hancock showed that people are much less comfortable identifying donors that meet circulatory criteria. And we need education, and we need systematic, standardized ways of doing it, so it doesn't just rely on individuals. This work from my friend and colleague Matthew Weiss showed us that it's a very it's a common event for physicians not to refer. When he polled ICU physicians and asked, have you ever not referred a potential donor, more than half of them said yeah, and I'll show you in a minute all the different reasons. And then 43% said, I've also seen a colleague not refer someone. So why do we do this? We're not bad people. Everybody's trying to do the right thing, but there's misconceptions about who would be eligible. We don't want to distress families. Maybe there's a conflict ethically or medical legally with the family. And the last thing we want to do is give the impression that our intent is to take their family members' organs. There's bias here as well in terms of ethnicity, religious, implicit and explicit bias, where we say in our minds that particular culture or religion don't donate, so there's no point in me asking. This sense of from the family of wanting to get it over with, leave the ICU, and you can see some of the other reasons there. So we I'm just going to check how we're doing on time. Good. So we did this study where we tried to actually measure the preventable harm in our Canadian system through a descriptive study by looking at how frequently missed identification or referral happened. So we did this by looking at requesting from all the ODOs across the country their donor definitions and their data for 3 years, 2016 to 2018. And then with knowing their own identification and referral rates, their approach rates, their consent rates, we did some estimations. And this is what we learned. So the first thing we learned is that ODOs didn't have this data. So of all the ODOs, only 4 were able to provide numbers. So lesson learned number 1, we need a system where all ODOs have the capacity and the definitions and the processes to collect data on missed identification or referral, consent rates, eligibility rates, all of it. And that's been part of the ODTC project to work towards that. The second thing we learned was misses were happening. So from those 4 ODOs across the 3 years we looked, there were 75 to 105 missed IDR, so identification or referral, what we called safety events. They were not identified and they were not referred. Now, were those safety events significant? So, what was the final? Well, I'll just take you through this. It'll be easier. So each of these ODOs had their own approach rate. So we use that to apply to the number of misses. And so that brought it down to 63 to 76, which if you think of it in terms of donor per million, that's 3.6 to 4.5 donor per million. So not an insignificant number. Then we applied that consent rate that would have been applicable in that particular ODO, 37 to 41 patients would have been approached and would have given consent. And using 3 organs per donor left us with 111 to 123 per year, so a total of 354 potential missed transplants just from missed identification of referral in only 4 ODOs. And that is 6.4 to 7.3 transplants per million, which would increase the Canadian transplant per million rate by more than 10%. So we worked with all of the ODOs to come up with a national clinical trigger. Many ODOs had their own, but we thought it could be helpful if we aligned the country around this. And so this is what the national clinical trigger looks like. And then I'm going to show you Alberta South and North, and you can compare and see. So we took the philosophical approach of being more broad and leaving the filtering to the ODO so that we are not inadvertently biasing and losing patients because of our lack of knowledge, our biases, our misinformation. So ventilated could be invasive, non-invasive, or, you know, the asterisk is mechanically supported either with VAD or ECMO. And there's an end-of-life care plan in place, or there's going to be a discussion to put a plan in place. And that too was a lot of discussion, you know, about should it be only once it's conducted or once it's planned? But I'm going to explain in a minute what the advantage of including the end-of-life care or withdrawal discussion being in the planned phase. And then we were very restrictive in our absolute exclusion criteria because we know that things are always evolving. Each ODO has its particularities. You know, for example, COVID was an exclusion, then it wasn't. So these were the 4 things that everyone could agree on that would be non-starters. So not common, well, except for the active cancer, metastatic cancer, but the other 3, 4 not too common, but at least it makes it clear what the absolute exclusions are. So thanks to Jahan, Lalani was able to obtain from one of you, I guess, I didn't hear exactly who. So we put together the North and South because they're very similar. So similarly, you guys start with mechanically ventilated. The decision to change to a C goal of care, which I reviewed, is really where the prioritization is comfort over prolonging life. So that's, you know, end of life care discussions. I think that's quite similar. And what is actually a very logical criteria, medically supportable, because if the patient is imminently, you know, going to lose their blood pressure and such, it's going to be hard to proceed down the donation pathway. And then similarly, you have the malignancy question. And then there's a little bit of a difference that it's focused on the neurologic criteria, and for sure that is the majority. So that's one aspect where we're a little more broad. The downside is that under the national trigger that we propose and are advocating, there will be more calls to the ODO, but potentially less loss of potential donors. And we didn't put an age in there per se because we couldn't get a national agreement. People were doing different things, so we figured let it go to the ODO and then they'll apply the age criteria that's relevant. So getting back to the why have it be when the withdrawal discussion or the end of life discussion is being planned as opposed to where it's concluded. And this is really an important notion of the distinction between referral, formal referral, and what we call notification or consultation. So this is kind of like the clinical analogy of I'm a little bit worried the patient I'm taking care of may have a cardiac issue, and you know, but I want to do a bit more evaluation before I do a formal cardiology consult. But then I think, you know what, I'm already drawing blood, you know, maybe I'm going to give my cardiologist like a quick call, have a brief discussion, give them a bit of background, give them the option. Maybe they prefer to do the consult now than tomorrow, depending on their scheduling. They can give some input into some of the testing we're doing. So this is a similar idea. You know, the ODO is a bunch of experts. And they can give us a lot of guidance about next steps. And in some cases, when we're talking about patients that are in, peripheral hospitals that may not be the main academic center in a big city, it also gives them time to plan and organize their resources because we know the whole donation process is quite complex. So we see a lot of value in that early notification and consultation, but it is distinct from where the mandatory referral should happen, where really there is that firm plan to withdraw life-sustaining therapies or the death by neurologic criteria is confirmed. So I think in the interest in time, so we have some more time to discuss, I'm going to go by this, which is just to say that we, and it's a lot of great work, so I apologize that we didn't, I think it's going to be rushed if we do it, but in brief, what we heard from a lot of the ODOs is that they needed clarity on, what are the data that we should be collecting. So we did a whole national project to define minimal data set for organ donation and test that it was possible to collect it by working with all the ODOs across the country. So we now have defined this minimal donation data set. And this is just as an example, the data set for utilized in each of the categories. So you can see what we're expecting people to collect, and it builds on itself through each step of the donation process. And we've also created, in collaboration with the ODO, these very helpful tools for donor audits, which is the processes which we do chart review to identify the misses, and even these automated calculators to calculate what the referral approach consent rates are. So everybody can do it the same way. You just plug your numbers in and Excel does the math for you. So I think the summary is important, which is that we the data set that we were able to recommend can be feasibly collected by most jurisdiction, and it does help us assess the system performance. It helped us familiarize the ODOs with the data set because they've had a chance to practice it and try it out. And with the experts and the users co-collaborating, we were able to co-develop these knowledge translations tools so that the adoption in the future will, I think, be smoother. Very important reminder of this amazing tool, the Canadian Clinical Guide to Organ Donation. You can scan the QR code here. There's a number of modules that are completely free that you, trainees, colleagues may be interested. You can see these are the modules there. I was involved in the identification and referral module, and now there's the other ones here. So you just sign up and you get access, and there's a lot of tools and learning accessible there. And so I'm going to leave you with this, and then we'll have about 15 minutes for discussion. So again, I think we have to remember our responsibility and our job and who we're accountable to, both as individual practitioners, but more so as a donation system. And that is both to the families who are grieving the loss of their loved ones and ensuring that they are given their choice, not just because it's nice, but because it's their right. It's their right to have that choice to accept or decline donation. And also to the vulnerable Canadians, the over 4,000 that remain on the transplant wait list, who are counting on all of us to do our best to end their wait. So I will stop sharing there and hope to see some of you on screen and have some discussion.
That's amazing. Thank you so much for sharing that and your presentation. I learned lots. So I have one question in the chat that just says, can you please put up the QR code after your presentation? Thank you for this interesting information.
Yeah.
So just so that we can, I think, take another moment to scan that.
Yeah, I'll just click on that. I'll do that.
Sean, I saw that you did have your hand up. I don't know if that was a question or.
That was a pause, but actually I do have a question. I really like the idea, and I know it's been floating around for a couple of years now, of considering missed donation opportunities as critical safety events because of the downstream implications for transplant patients missing out on their potential gift of life. I can see how that would be very influential inside of the choir here. I mean, everybody on here are donation professionals, transplant professionals, researchers dedicated to this field. Have you found, or have others found, that is an influential argument to OR scheduling and budgeting? Is it influential to the other areas? Because donation and transplant takes a small army to pull off, and does it have any reach or impact beyond the D&P committed folks?
Good question, Sean. So I haven't fully, and others may want to jump in because maybe they have their own experience. I haven't tested the theory at that level, to say, in my own practice per se. But I can certainly say that when we have been doing this work at the ministries level, right, and we presented to the health minister and such, it's very compelling to them. Very compelling. It gives people really great pause.
Yeah, I can see that. That's great.
Are there other questions? I don't see any hands up or anything in the chat to me directly. Remember, if you don't want to share to the group, you can also share to me directly for your chat. I do just have a question myself. So just with our journey of like being an angel donor family and having these conversations and talking to people, I get lots of people concerned that the doctors won't do everything they can to save you yourself. But then your conversation about how you talked about like thinking about the nameless patient or someone else, I guess, but we're so trained to think about the patient directly in front of us. How has that been with like training staff, having those conversations, like just changing the mindset in that way, but also being aware that we are doing everything we can for the patient that's in front of us here?
Yeah. That conflict is always challenging to navigate, and I think it's come a long way over the years, right? Where ICU people had no role in donation because we were seen as being in complete conflict. What I think the reality is, though, is it's an easy concept for people who work in critical care areas to understand, because 1 week you're taking care of a donor, and then the next week you're taking care of a patient who's waiting. So it's easy to make it real for people. Terms of the conversations with the family, I think it's by respecting all of those, guidelines that people like Dr. Sam Shemy and so many of you have put in place to make sure that our processes around donation are so ethical. And in my own, really making, we like to say it's like the before and the after, we do all the before, and then there's this moment where we suddenly realize that, okay, it's a donation eligible patient. But, if I go back, I put that QR code on, but if I go back to this diagram for a sec, as I make you all nauseous, the likelihood of therapeutic benefit and the likelihood of end-of-life care, it's really that. It's becoming diminishing returns on the therapeutic benefit and the increasing of the end-of-life care. It's not a clean line in the sand. And in my own personal experience doing critical care, I find that there are definitely the odd families, and they're all over the news, that are very doubtful and questioning of what we do. But most families are saying things like, "Why didn't you talk to me about this yet?" Or they're bringing it to us, and we're so worried that, okay, this is the prognosis meeting, we must decouple it from the after meeting, and that's the right thing to do. But it's, then there's the mother right away saying, well, isn't there some way that this tragedy can help someone? So I think it's going to be a challenge that we all at the bedside continue to navigate. And, one of the lines that I have particularly felt is helpful to say to families when I do get to the point of, mentioning donation, just so that I can introduce the donor coordinator. I know each province has its own way of doing that. And I do believe in Alberta, you do have a physician initially driven approach. Is I default to the standard practice, and I tell families it's my obligation and legally to have this conversation with you. And my colleague Sam Shemy is actually a very close colleague of mine. He always tells a story that at one of the consensus meetings that he led, leading practice meetings, there was the mother of a donor, and she said her comment was, I'm already in hell. And, you think that asking me about donation is going to be like what ruins my day? Like, get over yourselves. Like, it's just all horrible. And now maybe there's something else that we have to talk about. Like, that's not where the trauma is. It's everything. So Yeah, that's what I kind of say to families is, you know, there's three things very standardly. We're at end of life. There are some things we have to talk about. Legacy building, you know, do you want to do handprints and footprints? Do you want to record your child's heartbeat? You know, donation. This is what we can talk about. Autopsy. So it's just routine, same for every single patient.
So we don't have any questions. I haven't received anything in the chat. I do have from the L West Lab. Fabulous talk. Thank you so much.
Leave that up.
I know we've gone to mandatory referral in Alberta. I don't know if some of the folks on the line from the donation programs can even talk to how that has changed the conversations here. I saw Carrie and a few others, but just more curiosity as well. How does that help these conversations? Like Dr. Zavalkoff said, there are some things that I just need to say now, or I'm required to say this rather than you know, some other type of an approach. I don't know if that's something anyone can comment on.
Yeah, I'd love to hear that as well.
Hi, Sean, it's Carrie. Hey, just a FYI, we have gone to the, it should be required referral, but our experience has been, we are trying to change a system, not so much individuals. So what we're seeing is as we do education, it picks up, but we're finding we're going to have to be constantly involved in terms of tissue. Now, in terms of organs, since we've come up with the SEND program, it's been phenomenal, the difference. The critical care folks are incredibly motivated, and our numbers have increased, huge increase in numbers, probably more than double, and the involvement has really been impressive. Thanks.
That's fantastic. I'm really, I mean, I'll put in a plug for next week too, but I really want to hear that perspective from Dr. Spence, who's critical care out of Lethbridge and a SEND physician and fairly new to this. So just how he, you know, addresses this as a regional referral donation physician himself. But I see there's a question from the West Lab.
Oh, sorry, it's Lori here. Sorry, I'm in transit, so I can't turn on my camera. That was a fabulous talk. Thank you so much for bringing that to our attention. And I guess just the previous comment has, has explained a little bit how the numbers in Alberta have increased because of the SEND program. And of course, there's active advocacy towards the new legislation and enacting that and so on. But do you have any comments on what the most effective ways are for education across the critical care community, who, especially people who may not have had the opportunity to be involved very much with donation? Do you feel like that's generally overall improving? I know Sam's been making efforts in this regard for as long as I've known him, which is a long time.
Hi, Lori. It's so nice to hear your voice. Sam introduced Lori and and I wish I could see you, but I understand you're on the move. So what can I say about education? Well, a few things. Ah, there she is. So a few things. As a program, as somebody who is the program director for our critical care training program for 9 years, I think like most things, it helps to get in there early. And so one of the things very tangibly we've done in the latest iteration of training guidelines is that with me and Jennifer Hancock being at the table, donation features front and center. Like you cannot graduate as a critical care physician anymore without knowing how to declare death by neurologic criteria and know how to identify and refer. So that's one thing. The other thing is I think that we also have to not be physician-centric on this and know that our best referrers may be and can be our nursing colleagues, our RT colleagues who are literally the ones pulling the tube out and have the opportunity to pause before that action and say, time out, did we consider donation? our social workers who are so embedded in the social and psychological aspects of care for the family, who, you know, may be privy to even conversations that come up that aren't brought to the medical team. And it really does not need to be in a general way, you know, only a doctor who makes that call or at least raises that question. And then, you know, we're just submitting a paper about high performers across Canada, and it's a qualitative study on what makes a program a high performer in terms of identification and referral, and what do they have in common. So look out for that, because there's some nice commonalities, such things like having a really positive and tight relationship with your donor coordinator, who then becomes this real-time, in the moment educator, because he or she is circulating regularly and points out misses and congratulates the team through different mechanisms. So that's one feature. The other is these recognition letters, where, you know, maybe I haven't been involved with the donation, but in the lunchroom is this letter saying, you know, because of the team's great work, these patients have received a donation, kind of brings it to mind for those of us, because it remains a rare event, you know. So if you're not in the right place at the right time as a clinician, you can miss it. So all of those things, I think that will come out in that high performing paper, will help those who are still more struggling identify where it's worth putting the energy to do better.
Yeah, that's a really good point about we're too physician centric. I applaud the educational efforts for the younger intensivists, but there's still a lot of oldies like me who are in the intensive care, you know, programs across the country. And I think bringing as you've just said, bringing the team members who are not physicians into the whole dialogue it's so helpful, I would imagine. So that's really, I applaud that, and I'll look forward to seeing that article come out.